It gives me great pleasure today to present our second MISHC Mitral webinar. We are really honored today to have a very powerhouse of a guest speaker, Dr. Guerrero, who's very well known to us, and I'll introduce her properly as the time comes. We would like to share some of the work we've done in this group so far. And what we would like to do to get things moving is to get quickly to our presentations, because we would like to give Dr. Guerrero as much time as possible to give her presentations and maybe even involved in some discussions afterwards. And then after that, we'll have a publications update by Ms. Mary Casey, our project manager, and we'll adjourn. Hopefully, our goal is to be on time and not have you stay too late in our meeting. So without much further ado, I would ask probably Pam if we can move to the next slide. Unfortunately for you, this was supposed to be Alessandro Vivacqua's presentation, but like most surgeons, time has no control and their work has no control, and he's doing an urgent case right now. So I will be discussing what Alessandro was supposed to discuss. So next slide, please. So as we have had a lot of experience in the aortic space, we thought as we move into the mitral domains, we said we could, as a group, as a consortium, come up with some goals. These are not VBR goals, but goals that we can report to each other to understand our standards and create some goals for quality improvement. We also, as a group, felt, and I have to give credit to all the people in this group, and I don't want to, maybe in the end, we can put a list of who they are, but I don't want to miss anyone, but so I'm not. We can list it up on our website in the group. But we felt that these goals would be very important to create an ideal of where we want to go, and I'll show some of these slides of how we got to these numbers. But also, I feel just as important as we create these goals, not only can they be VBR goals in the future, they are not right now, but we could also use these lanes and these elements for some research projects and some publications we can do in the future. And Ms. Casey will talk more about that. We come after sharing about 25, and there were emails that went back and forth. We nailed it down. We sort of tapered it down to these 6 goals. We felt that we should document resistance to GDMT for functional cases in over 75% of cases. Shared decision-making should be documented in over 75% of cases. We should report our gradients post-TEER at 30 days and 1 year, and I'll go into those numbers. And although this number is a bit liberal with reduction of MR to more than 2+ should be in less than 20% of cases, maybe a bit confusing. So less than 20% of cases should have 2+ MR. When we think about data, and this is very similar to what we see in TVT, but as we move into the higher refined literature results, as you can see from the Pascal data and other studies that have been published recently with MitraClip, that number should be closer to 10%, but we'll start at 20 and we'll refine as we get more experience. I think this is also critically important. I don't want to belabor this too much, because as we move into the tricuspid space, our follow-up and documentation of our new device is going to be critical, because the FDA is mandating this for long-term follow-up. Next slide, please. So the graph in the following slide, so these are blinded data. So these sites do not have any relation to any site in particular. And if you look at what our baseline, this is the third quarter and fourth quarter, Q3 and fourth quarter, the documentation of GDMT refractory for functional cases was 61.2%. So whereas some 3 or 4 sites here have good, are at target, there's still room for improvement. And we chose this because as we have some sites who have a lot of experience, as they share their experience of how to get to that, we can actually get everybody up to the number we aspire to. So we're at 61.2%, we can go to 75%. TVT does not report this, so this is something, again, an opportunity for us to publish and document and lead the way across the country. Next slide, please. Shared decision-making requires a discussion of the goals of care with the patient and documenting this in the discussion in the chart. So it's not just enough to say it, but we have to document it. It can be incorporated as a phrase into the EMR, And then there's a best practice protocol already now on the MISHC.org on our website. Our consortium's numbers of 66.8 falls before the TVT target of 70, not target, but number of 74.9. Our goal is to meet and beat the TVT number and go over 75%. So I think there's a lot of opportunity because some sites are falling slightly behind. Many sites are right up there. I think this is a documentation problem, not a performance problem. And with some guidance as to how to document this properly, we can easily reach this target. Next slide, please. Mean gradient. This is important that we document. Again, it's a documentation issue. I think most of us are getting echoes at 30 days. We are actually doing really well at 79.8. There's not much room for improvement. We're above TVT, but I think if we can get the few sites that are falling behind and bring them up to where we are for the rest of the group, we can actually also in this surpass TVT. Next slide, please. And then the same thing for 1 year. TVT does not report this, so this is also important that we have longer term follow-up than TVT. We can really work together to get these numbers and publish these numbers and show what we can do at 1 year and maintenance and care of our patients with functional mitral regurgitation. Next slide, please. And then this, I think, is very important. That I know this is difficult because sometimes we're doing salvage cases and we can argue whether the concept of green, yellow, orange cases in a tiered domain are something we can sort of get down into. But we should aspire to have as close to a surgical-like result in this domain. So although we sort of didn't aim so high at 20.3%, at less than 20% is our goal, TVT is at 17.2%. So we're not far off. I think ultimately, as we get more refined and we have other therapies for mitral care that goes beyond TEER, we will really like to get this number to less, in my dream, is 15 to 10%. Next slide. So with that in mind, I'll stop here. Any comments or questions we can put into the chat box, and maybe after Dr. Merhi speaks, we can maybe bring a couple of these up so we can group them together, and then we can come for the highlight of the evening, which will be Dr. Guerrero's talk. It gives me great pleasure now to introduce a friend, a colleague, and one of the leaders in the structural space in the state of Michigan and in the country. Dr. Merhi, as you all know, practices is head of the structural group at Corewell West. And he did his training at Beaumont Hospital. So I don't know if you and Dr. Guerrero overlapped or had some, maybe you can discuss that with us, Will, after this. But I have known Will for many, many years now. He's much younger than me, but he's been a leader in many of the TAVR studies and has a lot of interest and also an inventor in his own way. So it gives me great pleasure today to invite Dr. Merhi to talk to the next about our mitral data.
Oh my God, thank you, Stan, for the kind introduction. Yeah, in fact, I knew Mayra. Actually, I was a clinical fellow at Beaumont when she was the interventional fellow at Beaumont. So I could say back then she was an amazing interventional fellow, and it was amazing then, and now she's even more amazing with all the, amazing things she's done in the field for structural heart disease. So really, really excited and happy to have her here as well. So next slide, please. Shown here are the site-specific mitral TEER volumes for the last 4 quarters that are available from TVT. Now, there are 16 sites in Michigan that are performing TEER, and as you can see, the distribution of mitral TEER volumes per site ranges between 2 and 93 cases. So, next slide, please. Now, KCCQ's quality of life scores are mandated for all time points, including baseline, 30 days, and 1 year in the mitral TEER national coverage document for reimbursement. Now, the Michigan Collaborative completion mean is 90.7%. TVT does not report completion percentages at baseline. You can see here that about half of the 16 sites in Michigan achieved a 100% compliance rate at obtaining baseline KCCQ. So I think amazing work there. Next slide, please. The mitral tier KCC completion rate at 30-day follow-up is shown here. The Michigan collaborative mean was 83.6% compared to the TVT mean of 69.4%. Of note, there were 3 centers in the collaborative that had a 100% completion rate. And I share Stan's comments on this. I think this might be worthwhile to have the centers that are achieving these rates share their pathways and their processes in achieving this. Of course, the data is unblinded, but something very, I think, would help at least me and other centers as well. So, next slide, please. Here are the rates for the mitral tier KCCQ completion rate at 1 year. You can see we have some work to do at improving the collaborative's rates. The mean was 52.2%. Again, the TVT registry does not report the national KCCQ completion rate. Next slide, please. As previously mentioned, CMS requires follow-up for mitral tier patients to 1 year. MISHC's 30-day follow-up completion rate is higher than the national average at 96.2%. compared to the TVT rate of 92.7%. So I think phenomenal work there. Next slide, please. The MISHC mitral tier follow-up completion rate at 1 year was 93.2%. TVT does not report the national average. Follow-up completion percentages address basic status entry. So it doesn't include KCCQs and TTE variables necessarily. You can get a follow-up to count as submitted without entering a KCCQ or a TTE. Next slide, please. Now, cardiac rehab referral prior to discharge has been found to increase utilization when recommended as part of the next phase of care. MISHC's referral mean is 74.5%. In order to claim yes for cardiac rehab referral prior to discharge, a discussion about the importance of cardiac rehab must be documented and a referral must be sent. Top 5 centers were able to refer patients greater than 94% of the time. So excellent work there. Next slide, please. Heart failure is the #1 reason for readmission at 30 days. The MISHC mean was 5.4%. TVT registry does not report on heart failure readmissions alone. The data I find is interesting as there are 4 sites with no heart failure readmissions at 30 days. Again, I think might be a good opportunity to share best practices amongst the collaborative. Next slide, please. All readmissions at 30 days within the collaborative was 15.2%. The TVT rate is 9.5% for the same time period. Mitral tier readmission categories are cardiac, heart failure, non-cardiac, or anything else. TVT counts only actual readmissions, so a 23-hour stay won't count. Next slide, please. The MISHC quality of life scores at baseline and 30 days are shown here per site. TVT does not report quality of life at 30 days, but the TVT baseline score is higher than the MISHC score by 7.4 points. You can see baseline scores are reported by the green bars and 30-day scores by the blue bars, with all centers showing improvement in quality of life scores. So I think overall, excellent work amongst the collaborative, but I share Stan's sentiment that there are potential opportunities here to share best practices. And of course, all the sites are blinded at this point. So thank you.
Thank you. Well, any comments or questions at this point? And if there are none, we can save them for later in the meeting and basically move forward to the main event of the evening, have Dr. Guerrero talk to us. It gives me great pleasure and gives us all great pleasure to introduce Dr. Guerrero, who's well known to us both locally, but also from a national standpoint. Dr. Guerrero is an interventional cardiologist with over 20 years experience in the field. She completed her interventional training at the William Beaumont Hospital and then joined the faculty at Henry Ford, where she worked for 10 years, establishing the Structural Heart Disease Program and the Structural Heart Intervention and Fellowship Program, which has been fundamental for many people in the state who are trained and even internationally who have trained there and continue to excel in the field. She served as Director of Structural Intervention at the Evanston Hospital in Evanston, Illinois, from 2015 to 2018, where after which she joined one of my favorite places in the world and my first place I practiced, the Mayo Clinic in June of 2018 in Rochester, Minnesota. She is currently a professor of medicine at the Mayo Clinic Hospital in Rochester. Her main areas of interest are transcatheter mitral valve replacement, TMVR. She has served as national PI and co-PI in multiple clinical trials, including transcatheter mitral valve repair and replacement. She is the Associate Program Director for the Cardiovascular Medicine Fellowship Program and the Chair of Diversity and Inclusion for the Department of Cardiovascular Medicine at the Mayo Clinic, Rochester, Minnesota. Apart from one of all these accolades, Dr. Guerrero is one of the nicest people I've ever met. Whenever you, at a meeting or in any setting, you ask for her advice, and she always is willing to give it willingly and always doing her utmost to make sure that all of us succeed in any endeavor we are trying to do. So again, it is with utmost pleasure that I am given the opportunity to introduce Dr. Guerrero for this talk. Thank you.
Mayra, I think you're muted.
Oh, I'm sorry. You didn't hear any of that.
No.
I'm so sorry. I was just saying that thank you so much for the introduction. I'm really humbled to hear, all that. And it's a pleasure, particularly, sharing this space with my colleagues like Will. I'm so proud of you, and Amar Abbas, likewise. Thank you for the invitation. And this topic is a very important topic for me, one of my favorites, or my favorite, I should say. And I would like to emphasize that ViMAC started in Michigan. So it's good to talk to you about that. I wanted to focus on the 10-year journey of what has been transcatheter mitral valve replacement and mitral annular calcification, which is mostly ViMAC, but now it's expanding to new dedicated mitral devices. These are my disclosures. And I thought I should start with a real case. This is a patient that we just saw a few months ago at Mayo Clinic. Believe it or not, this is a mitral valve that is barely opening. This is a 62-year-old male who has a history of Hodgkin's lymphoma, for which he received chest radiation and had a prior TAVR and untreated calcific MS, and was admitted to our CCU in cardiogenic shock due to critical calcific mitral stenosis. He was intubated on 3 pressors. He was obviously considered high surgical risk, and was asked to evaluate him for possible transcatheter mitral valve replacement, but he was obviously high risk for TMVR-induced LVOT obstruction because he had prior aortic stenosis, and the chamber, when you have both aortic stenosis and mitral stenosis, the LV chambers tend to be smaller, and they are almost always have high risk of TMVR-induced LVOT obstruction. So I wanted to just show you this because this is a real life, and we'll go back to the case after we review some data. And I'm just having difficulty advancing the slides now. Can I have control of the slides again?
To get control, Dr. Guerrero, just click on the desktop and then advance the slide. But let me mute myself real quick.
Thank you very much. Okay, our learning objectives will be to describe the rationale of why we need ViMAC and also early results of ViMAC, to review tools and techniques that we have developed to improve outcomes, and to delineate ongoing pivotal clinical trials of TMVR in MAC. So patients who have MAC of this degree, there are high-risk patients before they develop valvular dysfunction. They are often female, old, with multiple comorbidities. They have high risk of cardiovascular disease, high risk of cardiovascular death, and all-cause death. So they're high risk even even before they develop valve dysfunction. And it is more common than we thought. This study from Mayo Clinic evaluated 24,400 patients who had echo in 2015, and we found that 23% of them, this is all comers, This is not valve MAC, just all comers, and 23% had MAC on echo. And as you can see, compared with no MAC, these patients were older than patients without MAC and had multiple comorbidities. So just corroborating what we knew. And when you look at the survival of those patients on the right side, you'll see that on the red line, patients who had MAC and mitral valve dysfunction had the lowest survival compared with patients without MAC. And when you look at mitral stenosis only, this is another study from Mayo Clinic, 200 patients. When mitral stenosis is severe, the survival is even much lower compared with less degree of severity of mitral stenosis. So it's associated with poor outcomes. And then we wanted to evaluate if mitral valve intervention can change the outcomes. This is a subsequent study of the same population that I told you, but just looking at patients who had MAC and severe mitral valve dysfunction and evaluating the ones who had intervention versus no intervention. And this study was using patients from 2015 and before TMVR was implemented. So we're talking surgery basically, or TEER. And in this retrospective study, we found that patients who had intervention had higher survival than patients without intervention, but obviously there can be a lot of confounding factors, or there could be bias. This is not prospective data, but maybe patients who had intervention can do better. The problem is that most of these patients are not offered surgery because they have high surgical risk due to the comorbidities that we already mentioned and the technical challenges that are associated with very severe MAC, like the case that I showed you initially. So if you cannot do surgery, then can you do transcatheter repair maybe? But this is not an ideal option. For example, for patients who had stenosis, you could consider valvuloplasty. However, the technical success is limited. We know the gradients come back, and there is an unclear risk of mitral regurgitation once you inflate the balloon. You could consider TEER in patients who have regurgitation, but the problem here is the opposite. You have high risk of stenosis, either immediately after the implant or later on. And there are case reports of patients who have to have the clip removed surgically because they develop stenosis over time. MAC is a progressive condition that only gets worse with time. So TEER is not a good option either in many of these patients. And the newer therapies like this, repair therapies like this are probably also unlikely to work in severe MAC, like the one that I showed you. So that was the rationale why about a decade ago, several of us started thinking of using an aortic transcatheter valve because there were no dedicated mitral devices at that time. And I had the honor of doing this with my team and colleagues at Henry Ford Hospital. We did the first transeptal transcatheter mitral valve replacement in MAC using a SAPIEN aortic device. And that was the beginning of this 10-year journey. We then implemented the TMVR in MAC Global Registry that captured the earliest experience around the world with valve in MAC. And then we did the prospective trial of the mitral EFS, and then an preliminary analysis of early data and TVT. So with those initial studies, we learned many things about the problems that can happen with valve in MAC. We learned to improve patient selection and develop techniques to improve outcomes. And I'll talk to you a little bit about that. So the technique has evolved. There were some earlier reports of open transatrial valve in MAC, which is still being done at some centers in patients who are good candidates for that. Then transapical were the first two reports that were done prior to transeptal. But once transeptal became an option, it's less invasive and is, I think, the best option for the patients who have anatomy that is favorable for transeptal. So the early outcomes, I think we need to know where we come from to understand where we're going, and we have to acknowledge that the outcomes initially were not good. There was a high mortality at 30 days of 25% at the beginning, and then 50% mortality in 1 year. But we must remember that these patients had an STS score of 15%. And just to put this in perspective, even in partner one, in the high risk, inoperable patients, the STS score was not that high. I believe it was around 11. So these were all patients with a very high surgical risk or high risk in general. Then on the right side, we see the registry led by the Cedars-Sinai team, where they collected ViMAC, valve ring, and valve patients, and they even had a higher mortality. At 30 days was 34% in their early experience of 58 ViMAC cases. And at 1 year was 62%. So yes, it can be high, and if we're not careful, even though the outcomes are improving, and I'll show you that, it's important that we don't repeat the same mistakes. And that's why we want to talk about this, because if new centers start doing this procedure without following the recommendations based on what we have learned over this last 10 years, it's quite possible that we may see an increase in outcomes, of poor outcomes or increased mortality like this. So that's why this slide, even though it's old, it's important, because we don't want to go back to that type of higher mortality. So these were the main challenges that we had identified: LVOT obstruction, valve embolization, and paravalvular leak. And we have implemented tools to predict and prevent LVOT obstruction. Same for transcatheter valve embolization. And paravalvular leak is still a problem, but at least is often not lethal like LVOT obstruction is, or valve embolization. And this is the slide that shows how we learn the hard way about LVOT obstruction. This is a pathology specimen of a patient who died from a complication. This patient developed acute LVOT obstruction after a transcatheter valve ViMAC using an aortic device. And we learned here that the anterior leaflet covers the stent frame. So the open cells, the last row of the cells in the stent frame that are normally open, allowing flow in the LVOT, they're not open anymore because the anterior leaflet covers that. So the remaining space that you see here is what now we call the neo-LVOT on CT scan. Now we have tools that can allow us to make the same slice of the heart on CT scan. You can place a virtual valve before you actually do the procedure, which is illustrated in pink. And then you can measure the remaining space to see if you're going to have enough room to allow blood flow in the LVOT, or if you are going to have obstruction, like in this case. So that helps us identify patients at risk. And once you identify a patient at risk, that you can do something to prevent LVOT obstruction, because this was the most important independent predictor of acute as well as 1 year mortality in the TMVR in my global registry. But we have developed techniques that we divide them into categories, like septal reduction strategies. The first one was alcohol septal ablation to acutely reduce LVOT obstruction, which also started in Michigan. Now we are also utilizing radiofrequency septal ablation, preemptively alcohol or radiofrequency septal ablation. And then you have anterior leaflet strategies, either surgical resection during an open transatrial valve ViMAC, or the percutaneous laceration during a transeptal valve ViMAC. And this slide just shows the summary of how we implemented the role of alcohol septal ablation. So a few words about mitral EFS. In that trial, we had 31 patients in the valve ViMAC arm, of which half and half were transeptal, the other ones were transatrial. But of the non-transatrial cases, so 16 were non-transatrial, 15 were transeptal, one was transapical due to some problems with anatomy that was not favorable for transeptal. That's why this was treated with transapical access. But the first patient was in Michigan. It was a transeptal valve ViMAC that got complicated with LVOT obstruction, and Dr. O'Neill did the bailout alcohol septal ablation at Henry Ford, and which established the proof of concept. The second case was at Evanston Hospital, was the transapical case. And this one also developed LVOT obstruction and was treated with alcohol septal ablation with initial success. But this patient developed recurrence of gradient the following day because of edema in the septum. So that made us realize that if you need alcohol septal ablation, it's better to do it weeks ahead before the procedure than than doing it acutely if you see LVOT obstruction. So the remaining 14 patients, out of those remaining 14, 7 were identified to be at high risk of LVOT obstruction based on the CT, just like the one that I showed you. And those patients were treated with preemptive alcohol septal ablation 3 to 4 weeks prior to the valve ViMAC procedure. And this was completely a game changer because 100% of these patients survived. They were discharged from the hospital and they were alive at 30 days. So that's the beginning of the role of preemptive alcohol septal ablation. And just to illustrate in quickly, how these patients look on CT, you have a thick ventricular septum. You put the virtual valve illustrated in pink. You see there's a reduction in the space in the LVOT, but after septal ablation, you see how the septal thickness is significantly reduced. Then you place the transcatheter valve and you see much more space in the LVOT. And now this is a CT post valve ViMAC where this patient underwent valve ViMAC without LVOT obstruction. I'm sorry, there's a lag on the animations here. So this slide is busy, but it's important just to give you the message that the outcomes are improving. I have heard at meetings, from operators at other centers who have expressed concerns about the risk of alcohol septal ablation. And yes, it's not free of risk. We have to be careful how we do this, but the contemporary results are better than the initial experience. This is a single center study from Mayo Clinic where we evaluated the role of alcohol septal ablation, comparing the outcomes of when you do this preemptively prior to valve ViMAC in 22 patients, compared with the standard routine alcohol septal ablation that you do for HOCM patients, compared with 80 patients. And you can see on the top left the difference in the septal thickness after alcohol septal ablation. So there's significant reduction. Here on the bottom left, we see the septal thickness. When you do this for TMVR, the thickness of the septum is not as high as when you do this for HOCM. So there's a clear difference. And when you do the procedure, you don't have LVOT gradient, so you're not really chasing a gradient. So there are some differences during the procedure. So you don't need to give 3 or 5 cc's of alcohol. So I think the key message here is if you are going to do this prior to a valve ViMAC or any other TMVR device in MAC, 1 cc may be all you need, or sometimes even less if the thickness is not that much. So 1 cc, very rarely you need more than that. Just go with 1 and you'll have better outcomes. With just an average of about 1 cc, you may see an increase in the neo LVOT. In this case, it was 97 millimeters of mercury of the space in the LVOT, which is a generous increase in size. And the outcomes of these patients, when you look at the mortality at 30 days, was 0 in the TMVR group, and it was 4% in the HOCM group, despite being younger and with less comorbidities. So it just tells us that being careful, you can have safe alcohol septal ablation in many patients, and that can make help those patients become eligible for TMVR in MAC. And when alcohol doesn't work, or when the anatomy is not good, you don't have a good septal target, you can do radiofrequency ablation. As you can see in all these yellow arrows, after alcohol septal ablation, there was not enough improvement. And then we did radiofrequency septal ablation. And you can see now on the right side, the significant increase in the space in the LVOT space after radiofrequency septal ablation. And this how this patient become eligible for a safe transeptal valve ViMAC. So it is a good option. Transatral, I'm not going to say much about this because I think you have heard this a lot. It's basically surgery with a transatral implantation of a transcatheter valve. You remove the anterior leaflet, place anchoring sutures, and then you place the device. In carefully selected patients, outcomes can be good, but not many patients can tolerate such an aggressive intervention. Therefore, lampoon in patients who have good anatomy is becoming more popular because it's less invasive. And the initial outcomes of the trial were reasonable with the 30-day mortality was still 13%. So obviously we need to improve patient selection. But the purpose of lampoon is to percutaneously lacerate the leaflet to make room for flow through the open cells of the stent frame. So it will work in this type of technology, but it may not work in other dedicated mitral devices. And there are two things that you need to consider if you're going to do lampoon. Please measure the two things: the frame neo-LVOT, which is the distance, the space in the LVOT right here where the ventricular edge of the stent is in closest proximity with the septum, but also the skirt neo-LVOT, which is basically the remaining space in the LVOT at the level of the skirt of the stent frame. Why? Because if you lacerate the leaflet, you can still have obstruction of flow that is caused by the skirt of the stent frame. So don't think that just because you're going to do lampoon, you're going to be free of risk of LVOT obstruction. You can still have catastrophic risk or LVOT obstruction just from the skirt. So we need to make sure that there's going to be enough room after adequate septal ablation. And just a few words about newer techniques like the Sesame, which is septal scoring along the midline endocardium. It's basically a lampoon of the septum where the inventors of the lampoon technique also developed this technique where an electrified wire is introduced through the septum. And then you create the bend of the wire that they call the flying V, and then you electrify that wire and you pull the wire, lacerating the septum, and this is the type of result that you have. I have not had the need to do one yet, but I think if I need to do one, I would be happy to use this technique. And another recent technique is Batman. And this Batman and Robin, actually, I just forgot to add that slide. But now Batman is balloon-assisted translocation of the mitral anterior leaflet. It's basically you lacerate the leaflet and implant the valve. So you do a balloon valvuloplasty or perforation of the anterior leaflet to make room for the delivery of the transcatheter valve. And then you implant the valve and push the anterior leaflet posteriorly. But the reality is that we do need dedicated devices, and there are already some devices that are being developed to provide a more controlled and predictable laceration of the anterior leaflet. And that hopefully is going to be more user-friendly, because all the techniques that I just recently showed you, they are quite complex. And hopefully we'll have these tools available soon. So changing topics, I just gave you a summary of multiple techniques to decrease the risk of LVOT obstruction, so you don't have to have a patient or a catastrophic result like the one that I showed you with that pathology specimen. So that's the goal of this, to give you all the tools so you don't have to see that again or ever. And moving now to another complication that you want to prevent, which is embolization. So here we develop a CT MAC score that can help you select the patients that have enough calcium to anchor an aortic transcatheter valve, basically a SAPIEN 3. Because as we know, SAPIEN 3 was designed for aortic stenosis, not for mitral stenosis, and it doesn't have any specific anchoring mechanism. So it relies on the force of the calcium. So we looked at anatomic features on CT, like the thickness of the calcium, the degree of circumference involvement, whether trigons are involved or not, and leaflets are involved or not, and then we give points according to the severity. Thickness less than 5 millimeters is 1 point, 5 to 10 millimeters is 2 points, and 10 millimeters or more is 3 points. The distribution less than 180 degrees is 1 point, more than 180 but less than 270 is 2 points, and more than 270 is 3 points. And then 1 point for each trigon and 1 point for each leaflet. And the total score is 10. And we consider severe when you have a score of 7 or greater, moderate between 4 and 6, and mild if it's less than 3. And then we validated the score utilizing the data from the TMVR and MAC Global Registry. These are some examples of what would be mild, moderate, and severe. So in addition to predict embolization, which I'll show you in a moment, the other goal of this score was to provide a more systematic degree of or grading of the severity of MAC, because sometimes people call severe MAC something mild like this, and it's not. So we wanted to provide a more uniform way to grade MAC severity as well. So in the TMVR in MAC Global Registry, there were 117 patients, of which 87 had adequate quality on those CT scans for analysis. The ones that were not good quality, that could not be evaluated and were rejected. And then there were 15 transatrial cases, and we eliminated those because you want to evaluate anchoring. When you do transatrial, you place sutures, so those would not be good cases for comparison. So we only evaluated transeptal or transapical cases. The mean score was 7.4 of those patients, so severe MAC really in those patients. And what we found, what you see in green is the cases that went well. In red are the valves that embolized. This is early experience, the first experience around the world many years ago. And in blue are the valves that had migration. And what you will notice is that if the MAC score was 7 or greater, most of those cases went well. But if the score was 6 or less, there was a 60% rate of valve migration or embolization, so extremely high. And that was obviously highly statistically significant. So that gives us the knowledge to say that if you don't have really severe MAC, when you have moderate or less, if the score is 6 or less, don't do valve in MAC, please. If the MAC score is 7 or greater, you could consider a SAPIEN 3, but also a dedicated transcatheter mitral valve. That may be an option. I'll pause here because I don't think I'm going through the details later about, if you have a score of 7, how do you choose one versus another one? Well, the problem with these patients is most of them have high risk of LVOT obstruction, like the case that I illustrated at the beginning. So they don't qualify for transcatheter mitral devices. So that's I think where the SAPIEN 3 has a specific role because you can do LEMPUN, and then you can facilitate safe transeptal valve in MAC in those patients. So that's why I think this is helpful to select those patients. So now in the next few slides, I'm just going to give you a summary of the outcomes. If you implement the tools that I have mentioned, what can you expect in terms of outcomes? All the learnings were from the earlier experience in retrospective studies. This is the first prospective study. We had valve in valve, valve in ring, and valve in MAC. And the valve in valve and valve in ring were all transeptal. I told you already, I'm sorry, let me go back. I told you already that in the native valve in MAC, they were half and half, and transeptal versus transatrial, open surgical transatrial. And this was not randomized. It was just based on anatomy. And utilizing the preemptive alcohol septal ablation, as I showed you earlier, we were able to obtain this type of outcomes in the transeptal cases. So the 30-day mortality for transeptal valve in MAC was 6.7%, but in transatrial with the open surgical approach was 21%, was 4 times higher, and at 1 year was 38%, versus a transeptal 30-day mortality of only 6.7% and 1 year mortality of 26%. So utilizing the CT MAC score and preemptive alcohol septal ablation, we were able to obtain this type of early outcomes in valve in MAC, which I consider that a significant progress compared with the poor outcomes that we saw in the TMVR in MAC Global Registry. There was improvement in symptoms in both arms. I want to show you the, let me just tell you, there were 0 embolizations in mitral EFS, no valve embolizations. The mean CT MAC score was 6.8. So the 1 year mortality was 33% for all of the patients. Of those, the transeptal had a 26% mortality, which is similar to Tendyne. Tendyne is a dedicated transapical TMVR device, and valve in MAC is not designed for MAC. And despite that, they had similar mortality or survival at 1 year. And at 2 years, the same, it was 39.9% in the mitral EFS, and it was 41.6% in the Tendyne global EFS. So similar. However, at 5 years, the survival of MAC patients are is not good. So these patients die, and many of these deaths are not even cardiac. They die for other reasons, similar to the valve ring group. These two had lower survival in the 36 range, 33 to 36% range, much inferior compared with the nice survival of 79% in the valve MAC. So these patients are all with multiple comorbidities. We need to do more work to improve selection of these patients to allow, improvement in the overall outcomes. But the patients who survived at 5 years, they experience, most of them experience improvement in symptoms. Let me start on the left with the reduction of mitral regurgitation. Most of them, 83%, had none or trace MR, despite, the risk of paravalvular leak. So most of them did not have, at 5 years, a significant leak. You could say that maybe this is natural selection. Maybe the ones who had leaks that didn't survive 5 years, it's possible. But at least we have some reassurance that the paravalvular leak problem is not that bad in carefully selected patients. And there was improvement of symptoms. What you see at the center is paired analysis, is the same patients year after year. And you can see the p-values are significant. At 1 year, most of them had NYHA class 1 or 2. At baseline, obviously, most of them were in NYHA class 3 or 4, and then symptoms improved to class 1 or 2 at 1 year. And then gradually, some, lose that benefit. At the end of 5 years, only half of them were in NYHA class 1 or 2. I don't know if this is due to diastolic dysfunction or competing risks of other comorbidities. And the quality of life scores are illustrated on the right side. So there was a significant improvement at 1 year and 2 years. The p-values became less significant after year 3 and 4 and 5. That's probably because of the small sample size. But what I'm trying to say is that at least most of the survivors experience some clinical improvement. And the valve gradients remain stable after 5 years. So very similar for all 3 groups. It's not uncommon that you do see gradients more than 5. These are not tiered cases. Usually they're around 6-ish, between 6 and 7, but they remain stable after 5 years. So that was mitral EFS. Now an update on mitral 2 pivotal trial. Because I showed you the outcomes with transeptal valve MAC were better than transatrial valve MAC, we decided not to study any other access other than just transeptal. And we also added an arm of natural history for patients who are not candidates for any intervention or who are not interested in intervention, hoping to be able to generate contemporary data on the outcomes of these patients, because we don't know if doing an intervention is going to help increase survival or symptoms for some patients, like I just showed you. So in the ViMAC arm, we are aiming to enroll 110 patients. They all are going to be treated in transeptal access. We need a CT max score of 7 or greater. And here the difference compared with mitral EFS is now we are allowing alcohol septal ablation or radiofrequency septal ablation or lampoon or the combination of any or all of those to decrease the risk of LVOT obstruction. And we are 90% done with enrollment. We just treated 100 patients already, so we need 10 more. And this is our contemporary algorithm. I'll slow down here because I just want to show you exactly what we do now. And it works. We just treated another patient yesterday, and I'll show you how we treated the patient that I showed you in the first slide. This is the algorithm that we follow. On CT, we check first the frame neo-LVOT, which is the LVOT space at the ventricular edge of the stent frame. If the frame neo-LVOT is more than 200 millimeters squared, which is rarely the case in valve MAC, then you don't have high risk of LVOT obstruction. You can proceed with your valve MAC without lampoon. But if the frame neo-LVOT is less than 200, then we check the skirt, like I showed you, where to check the skirt neo-LVOT. If the skirt neo-LVOT is less than 200, then we know that even after successful lampoon, you can have LVOT obstruction. Therefore, it would be wise to modify the septum to decrease that risk. So then what we do, we look at the septal branches, looking for any suitable target for alcohol ablation, and then as the septal thickness to make sure that it's at least 10 millimeter, which is usually the case. So if you have good septal target and good septal thickness, then we do alcohol ablation. But if not, then we do radiofrequency ablation. Now, then if our scapular LVOT is more than 200, you could do lampoon. However, we would recommend to also look at the interaction of the transcatheter valve with the endocardium, because sometimes the LVs are too small. And even though just scapular LVOT is okay, when you look at the transcatheter valve, the virtual valve, if it's touching the endocardium, that valve can get ejected with the contractility, and we have seen that migrate. That can get ejected. So it's best to modify the septum, even if your scapular LVOT is more than 200. You can modify that with alcohol septal ablation if there is endocardial interaction with the endocardium. If no, then you can do lampoon. And in some challenging anatomy, if there's too much calcium of the anterior leaflet, if you're not sure that the lampoon, the success of lampoon is what you want, because too much calcium, then we recommend to increase these thresholds to 250, because the lampoon doesn't always give you the result that you want. So this is the summary for how to approach now in contemporary days, the risk of LVOT obstruction. So this is a summary now of the ongoing pivotal trial. So I told you the Mitral 2 with 90% that with enrollment, but now there are newer dedicated devices that are evaluating TMVR in MAC. So Summit with the Tendyne valve is the enrollment is complete. Apollo, let me just go back, I'm sorry. Apollo is, the last time I checked, you may know more than me, it was more than 65% done with enrollment, and Circle is done enrolling, and Atlas already started enrollment. Before I forget, in Circle, the SAPIEN M3 just received CE mark approval in Europe. I haven't read all the document in detail, but it just happened a few days ago, last week. So this field is finally moving a little fast. So the early outcomes of TMVR in MAC with Tendyne had shown a 1-year mortality of 40%, like I showed you earlier. So these patients are high risk, SDO score of 8. This is early experience, so this is probably going to improve. As you know, in the Summit trial, which was initially dedicated to non-calcified valves, they added a MAC arm and completed enrollment soon. And those results, early results were presented at TCT in 2023, the 30-day outcomes of the first 103 patients in this study. Those were the clinical characteristics. But basically, the important thing here is that 30-day mortality was only 6.8%, and the predicted mortality by SDO score was 7%. So quite encouraging, at least the 30-day outcomes. And there was reduction. Most of them had no MR, and there was improvement in symptoms, and the 1-year outcomes are being collected. The data will be presented hopefully this year, and we anticipate FDA approval soon, also this year or early next year, hopefully this year. So the Apollo trial also added an arm of the MAC cohort, and it's enrolling fast. And Circle also added a MAC cohort. We're done with enrollment. We hope to present this data of the main, it has 3 arms, the commercial and ineligible for non-calcified valves, patients who are not suitable for TEER. We hope to present this main cohort data at TCT this year. It also has an arm for failed attempt of prior TEER, and then the MAC registry. As I said, it already received CE mark approval, so we hope there will be approval soon in the US, but not for calcified valves. I think it's going to be first for non-calcified valves and later on, hopefully, for calcified valves. And the Alta valve is a supraannular device that avoids the subvalvular space. Therefore, the risk of LVOT obstruction is not a risk and for this particular design. and already started enrolling. And it will have also a MAC cohort of up to 100 patients. So going back to our presentation, we're getting ready to conclude the presentation. This is the patient that we had to treat a few months ago. So if we go back to the prior slide, let me ask you, could we use Alta valve, supraannular? No, because this patient has stenosis, supraannular, valve is probably going to be more helpful only for regurgitation. Can you do Tendyne? That would be very difficult, particularly this patient is in cardiogenic shock on pressors. Can you do Sapien M3? I don't think you can navigate the medial commissure here to place the subvalvular dog to put the valve. Can you do Intrepid? I think that's also going to be very challenging. And I think will be high with any of those. So what do we do? Well, this is our CT analysis. So we measure the annulus area was 760. So that would tell us that we would need a 29 millimeters valve with extra volume, at least 5 cc's of extra volume. You always want to add extra volume to flare and help anchor the transcatheter valve. We were confident that we would have good anchoring, based on the MAC score. And you can see the calciums, the trigones are calcified. Then we measured the neo LVOT, and it was very small. As you can see, the frame neo LVOT was only 55, and the skirt neo LVOT was 168. So based on the algorithm that I showed you, if it's less than 200, then we know we need to modify the septum because a lampoon is not going to be enough. So I'm sorry, there's a delay here. So what we decided to do is urgent mitral valve balloon valvuloplasty as a bridge, plus preemptive alcohol septal ablation. So first we ballooned the valve, and then when there was a little bit of more opening of the valve, as you can see here, then we did the alcohol ablation. During the same procedure, the patient was extubated, was discharged home. I couldn't believe that we're not even talking nursing home. He went home, and he came back in 3 or 4 weeks for the repeat CT scan after alcohol septal ablation. And this is now the space in the LVOT. The neo LVOT increased to 135, and the skirt neo LVOT was now 264. So we did lampoon facilitated valve ViMAC. And this is the lampoon procedure. You have the 2 catheters. We do a transeptal access. So this is the V, the flying V, as you can see. We electrify the wire and then pull back and lacerate the leaflet. And then we were able to place our transcatheter valve via transeptal access. So this is the transcatheter valve being introduced. You can see the balloon pump. We always use balloon pump after lampoon because we see the acute MR and sometimes there's a compensation. And this is now the valve deployment. So the procedure, the valve implant was uneventful. The patient did well. And when we extubated the patient, like within the next 1 or 2 hours after that, the patient was feeling already immediately better. He said that he felt like his lungs got out of jail, literally. This is now the valve. Remember how it was barely open before? Now it's opening, there's no leak. And the patient did well and was discharged home on post-operative day 3. So this is a good example of a good outcome. So in summary, for mitral EFS and mitral 2 summary, in mitral EFS, I showed you that in carefully selected patients, transeptal valve ViMAC is associated with a 30-day mortality that is lower than predicted by the STS score. The 1 and 2 year mortality was similar to Tendyne and even similar to the early TEER experience based on the TVT reports. But however, it was associated with a low 33% survival at 5 years. However, survivors experienced sustained improvement of symptoms and quality of life, and there was stable transcatheter valve performance at 5 years. So that's EFS. And for mitral 2 pivotal trial, we're evaluating transeptal valve ViMAC in high-risk patients with a MAC score of 7. We allow any strategy to decrease the risk of LVOT obstruction that includes alcohol or radiofrequency septal ablation and leaflet modification with lampoon. They were 90% done with enrollment. So in conclusion, valve ViMAC is complex. It's associated with improved symptoms and quality of life, but a lower long-term survival than mitral valve and valve. So we still need to work on patient selection to improve those outcomes. And there are ongoing pivotal trials, one with an aortic device, which is mitral 2, and then at least 4 with dedicated mitral devices. We think that, well, I think that dedicated mitral devices may be the better solution for selected patients in MAC. But as I mentioned earlier, there are some that still are not going to qualify for those and may still benefit from an aortic device. And we think that there will be results of the two of those main pivotal trials presented this year, and hopefully approval by the FDA for high surgical risk patients either later in 2025 or early in 2026. And with that, I will end with my Minnesota and Arizona license plates that read TMVR in MAC, because this is the ICD code for MAC, which, by the way, I encourage you to use. It will be very helpful for research. Every time you see a patient with MAC, use the ICD code so that years from now, you can go back and do research retrospective on those patients. Okay, I'll stop, and thank you very much. Happy to answer any questions.
Dr. Guerrero, that was fantastic. I'll wait a few minutes to see if we have any questions on the chat or people want to come directly on and speak directly.
Stan, do you mind if I ask Mayra a question and say hello?
Of course, we owe this to you anyway, so thank you.
Hi,
No. Hi, Mayra. How are you? Thank you so much. What an incredible talk, an incredible journey. Really proud you were my co-fellow.
Likewise.
Remember all the times. Remember all the times in the fellows room and all the on calls and the meetings. So thank you again for coming and giving us this amazing lecture. Just out of your experience, have you noted any, I guess, presentational differences or procedural differences, or obviously incidents in patients who present with primarily mitral stenosis in MAC versus mitral regurgitation? And how do you approach these people differently, or you don't, or do you think they come in more severe? I mean, to have acute mitral, I guess, cardiogenic shock with mitral stenosis, that's a very rare, thing, to see. But how would you say that those patients differ when they present, and how urgent and is your approach different for them?
My personal bias is that I think that mitral stenosis is worse than mitral regurgitation because it's a mechanical problem. And with regurgitation, you could work on volume status, blood pressure, and other things that you can potentially, improve to stabilize the patient. And I think stenosis is worse. But honestly, I don't think that we know enough. We still need to do a lot more, analysis of the limited data that we have. But the options are also in treatment are different. There may be some MAC patients where really maybe you can do a TEER. I stopped doing TEER in MAC a long time ago. I think it's not good long term. So I think it's best to do TMVR. The difference in anatomy is important between these two groups. Mitral regurgitation patients have usually larger size ventricles. So your options for transcatheter mitral valve replacement, particularly with dedicated devices, are more. I have in another presentation a table where I compare the patient population, the echo baseline characteristics of, for example, the patients treated in Tendyne, treated in mitral EFS, TMVR in MAC Global Registry, TVT, and you can see all the registries with aortic devices. The LVs were different. The EF is normal, first of all. They have higher gradients, of course. The LV sizes are smaller. And when you compare those with Tendyne, the Tendyne patients have lower EFs. They have less gradients. They have higher degree of mitral regurgitation. So anatomically, they are different. And it works to our advantage in the mitral regurgitation because you have more options. You can do Tendyne, you can do any of the other dedicated devices, Intrepid or SAPIEN M3. And with stenosis, very rarely we can get a patient accepted in any of those trials. So I think with stenosis, we're limited to valve MAC in most of those patients at this time. I don't know if I answered your question.
That was perfect, Mayra. Thank you. I
Thank you.
appreciate it, and great seeing you again. Thank you.
Thank you. Likewise.
Mayra, can I ask a question? This is Ivan Hansen. It's great to see you again. I remember talking with you when you came for grand rounds to Beaumont not long ago. So thanks again for giving us this really nice talk and for all your pioneering work in this space. So just a couple questions. One is, what are your thoughts on shockwave valvuloplasty for calcific mitral stenosis? Is that adequate as a standalone therapy in any patient, or would you only consider that as a bridge? And then with the newer techniques for modification of the anterior mitral leaflet when you're planning TMVR, now that we have, Batman, Robin, you have to laugh at some of the names of these things, but have those supplanted, in your view, the traditional lampoon for modification?
Well, very important question. So talking about Batman and lampoon, I don't know that they are mutually exclusive, or I don't know. I think I don't know what's best. I think we definitely need dedicated devices. We at our center have not done a Batman. We may do one, but we haven't done one because we get the results that we want with the lampoon procedure. So same like with Sesame. So I have not personally had the need to do that. We may do it just to see if we can improve the technique and save time, because to be honest, they're very time consuming and resource consuming, meaning they cannot just be done by one attending in one fellow. You need like 3 or 4, people to do a lampoon procedure. So if we can more standardize the Batman technique and use less people, I don't know, there may be a value, but right now we have not necessarily implemented Batman in our center. And I'm sorry, the first question, what was the first question?
First question was, do you ever use valvuloplasty and specifically shockwave for calcific mitral stenosis? Is that ever a standalone therapy for you?
I tried one once, and it's hard to align. One small shockwave is not going to be, one small balloon is not going to be enough. You need like 2 or 3, right, of those peripheral balloons to be able to deliver the energy. That's only goes, so much farther. So I tried that. I didn't get the alignment that I was looking for. And in the end, I just took them out and just took a regular balloon, like a CMIT2, for example, at 26. And I don't think that a standalone is going to work, maybe as a bridge, but I think there would be a need to evaluate the outcomes of both, right? There's so many unanswered questions, and I don't know, please let me know if you know of any study that has compared the regular balloon, traditional balloon versus shockwave balloon to see, are the gradings really better? Are you reducing the risk of leak or other complications? So I don't know.
I'm not aware of any data. I've seen case reports, case series, but that's about it.
Thank you. And I had spoken to one of the leaders in Michigan of the shockwave utilization, and I don't think that they have a comparison group. So we'll see the report. And so right now you have reports of the outcomes with alcohol ablation. You have reports of some series of cases with radiofrequency. You have reports of the shockwave, in series of cases, and then you have the Batman, and then the Batman and Robin maybe, but they're not integrated in one comparison. So I don't know that we will ever know if one is superior to another one. But while we try to figure that out, I think that there will be a dedicated device that is going to come and take those or push those all away, I think.
I could not agree with you more. The Picardia Generation 2, which will be transeptal and has a different cutting mechanism, will be even better than the first generation, and it's going to make a big change from a speed and control of your cut. I had a question for you. With all these with Lampoon and Batman Robin, what is your recommendation about embolic protection devices?
That's a great question. I personally favor the use of Sentinel device for the Lampoon procedures when we can. And I say when we can because humbly, yesterday we did a case, and this patient, we just could not get a radial. I think it's been used before, very weak pulse, plus you would think that it's rare to see patients in shock. This patient, he's 57, the procedure went well. We were not able to place a Sentinel device, no stroke. So the rates of stroke have been low. So I'll answer your question, and then I'll add a comment about the hemodynamic compromise in these patients. So the stroke rates have been low in the single digits within the 1 year, and in EFS even out to 5 years, and also within the ongoing trials. So I don't know if really Lampoon increases the risk significantly. You would think normally that probably yes. So that's why we use it. But the rates of stroke have not been high. And we have done it without Lampoon and no stroke, like the one from yesterday. But a comment about the patient yesterday, very similar to the one that I showed you. As soon as the anesthesia team started the induction of anesthesia, so I go in the room and I find the patient in the cath lab with feet up. They were raising the legs because he had acute decompensation, and the blood pressure dropped to like 60 systolic. So we're getting ready to start. I had on the wall all the CT pictures, the ones that I showed you on the slides. I put them on the wall, and I have a 2-page document of all the steps, for the Lampoons and all the things that we're going to do, including, the right heart cath, the balloon pump, and all that. We had to skip all that and then just go to rescue in urgent valvuloplasty. That was going to be our plan because of the severe stenosis. So I don't know what's going on. If just like MAC per se, we think that the prevalence is increasing. I wonder if not just it's only increasing, but those patients are living longer and they're presenting very late to the point that we see them when they're very sick. And it's hard to fix them when they're at the end, of the disease process. They're very complex patients. And this one, 57, dialysis patient, of course.
Mayra, can I ask you a question? It's Matthew Romano, a cardiac surgeon from Michigan. 2 things. What is the mean size of the sapien that you're putting in? Because part of the problem with MAC patients, as we know, is usually they're smaller valves. And, that I assume what drives the gradients.
It's always, well, not always, most of the times is a 29. And I'm just
29, okay.
29, but we occasionally, we do use also the smaller ones. So let me.
And then just to follow up, so as you commented on, you think survival will improve because you're identifying better patients, everything. What % of patients do you turn down for this?
Many patients. So I was just looking at a report of just to give you an idea. So maybe about 20% lately have been 26 sapien 3. Most of them are 29, and most of them are with extra volume. So
Okay.
I don't know if the gradients are because of the valve size is small. I don't know. Yeah.
Okay, great. And then you were saying a pretty high screen failure rate.
I would say at least 50%. Yeah, if not more. And many of them become eligible after successful septal reduction. But there's still, I think I would say maybe 50 to 60% screen failure rate due to LVOT obstruction most of the time.
Dr. Guerrero, again, thank you very much. This was really informative and instructive as always. And thank you for your time. And hopefully one of these days we can invite you back in person to come be with us in one of our major meetings. Thank you again.
Thank you. No, thank you all very much. Thank you. Very nice to see you. Thank you.
Thanks, Mayra. Excellent talk. Thank you.
Thank you.
At this point, we're going to move on to our next part of our meeting, which is to explain our publication process. This is a live concept that we share among ourselves, but there are some steps we have to go through. It gives me the privilege now to introduce Merhi Casey, who's the project manager for this. Merhi is the BMC Squared and MISHC project manager and the BMC Squared lead for the Michigan Cardiac Rehab Network, or MISHR. She is also the new MISHC publication coordinator. She's the contact person that will work with the structural heart teams throughout Michigan to oversee development, review, and tracking of publications in Michigan. And in the mitral space, as I said in the beginning, we're going to have to we are trying to create some lanes that we can prospectively think are interesting for us and for the community at large. And Ms. Casey will now be talking to us about how we can get about with this. So we're not just sort of throwing a wide net, but have some very focused way we can do this in a very productive manner. Ms. Casey, to you.
Yeah, thank you for that introduction. You explained it all, so I'll just jump right into it. I am Merhi Casey, and I'm excited to share some of the updates we've made to the publication process. So starting off, I just want to start with why is this important? Why are we focusing on this? And none of this is news to anybody on this call, most likely, but structural heart is a rapidly evolving field. That means we have an opportunity to have an impact on long-term safety and effectiveness assessments. Publications are also a tool that we can use to influence guidelines and reimbursements, helping the ACC and AHA inform their guidelines, as well as CMS reimbursement policies and hospital adoption strategies. We also have an opportunity to enhance patient accessibility or access and eligibility with this work. Sorry, I can't advance my. Okay, here we go. So the purpose, why did MISHC and BMC2 take on this work? We really wanted to focus on improving transparency between the PI and the coordinating center, the various people that are working with the PIs and the author teams on these projects. We wanted to streamline communications and the handoffs between the different players at the different stages. We also, which goes hand in hand, we want to have clear expectations for all of the collaborators involved in this work. And ultimately, we want to provide high quality statistical and publication support for our PIs engaging in this important work. As we just covered, publications are very important for MISHC. And finally, and possibly one of the most important purposes or reasons behind this work is that we have to guarantee adherence to requirements from our funder, Blue Cross. We are stewards of this data. We don't own the data. And with that stewardship comes a lot of responsibilities and expectations. And so for every project that's using this data that we have to make sure that our funder we're doing the things that our funder is requiring of us in the different levels of oversight. So jumping into the key changes in the new process, one of the biggest changes is that all of the projects are going to start at one specific spot. We're going to have an electronic form that a PI would use to submit a proposal idea, and that would go to our statistician, and the work would just kind of unfold from there. We are also going to be incorporating early collaborator input from co-authors. Instead of having the input come from the co-authors at the end of the project, we're going to be incorporating that earlier on to avoid changes to the analysis plan from the get-go. We're also going to be incorporating a collaborative, team-based, team-created statement of work that will really be the roadmap for the analysis and the project itself. It'll detail the analysis plan, the stakeholder roles and expectations, as well as the anticipated timeframe for the work. And then finally, just to support all of our teams and our collaborators doing this work and knowing what's expected, we put together a collaborative or a comprehensive resource guide with the different expectations and then support materials to allow those expectations to be met by PIs at all different levels in their career. So the publication submission form is live on the MISHC website. It's under the publication and presentation tab. The orange arrow is where it says submit the form. That'll take you directly to the form that you submit if you have an idea you want to present or if you want to propose. And so given the importance of the publications, the reason why we're doing this publication improvement work is because there are definitely anticipated benefits for MISHC. First, we hope to create a publication portfolio at some point in the future, publication portfolio that really uses as a pipeline instead of just different projects happening all independent of each other. We also really want to use these publications and this streamlined, clear process to boost our physician engagement and allow everybody who's participating to be a part of this really exciting work. We want to improve the efficiency in getting these projects started and moving through the various milestones, as well as we want to, of course, focus on institutional recognition and making sure that we are, really doing good things with the data we have. So that is my last slide. I didn't put a slide in with my email address, but if anybody has any questions on this, we will share my email with in the follow-up email going out to everybody who attended this meeting, and I'm more than happy to answer questions or whatever's needed.
Thank you very much, Ms. Casey. I have a quick question, very quickly. Will there be a list of ongoing projects on the publications website? So if I have an idea, but someone else is already working on it, am I able to check if something's being done already in that domain?
That is an opportunity we can look into. I think that's a good idea. We can discuss it.
Okay. Any comments or questions? If not, in the sake of time, I mean, Ms. Casey will be sharing her email. And this fits into what we've been just saying. There are two work groups that we are going to ask for volunteers for participation. There is there's a mitral work group already involved, and we've decided that there's going to be two other areas we would like to have more global involvement from the community, because this is our program, not any committee or director's program. If you could use this QR code on the right here to participate, there's a MISHC mitral publication group that we would like to install and start moving forward with some of these ideas with the help of Ms. Casey and her group. And then, just as we had in the TAVR domain, a best practice work group. So please, any of you who are interested or would love to participate or want to be involved more in MISHC, this is an opportunity to use this QR code. And we'll leave it here for a while and also maybe have it also on our website to be able to maybe log into and participate. And then the TAVR work group participation is on a much global scale, higher scale. It used to sign up in the MISHC TAVR work group, which will work directly to MISHC TAVR in reporting, goal setting, publications, meeting planning, and best practice development. Another important group. The TAVR domain is much more robust with 31 sites now, a lot more data, and there's a lot of opportunities from publications and planning and having best practice developments, which we can set the tone for the rest of the country. So again, please get involved. This is our program, all of us, we're all members. Pam makes a comment. The QR codes will be included in the follow-up email in the coming day or two. So please feel free, if you can get it on time today, and share with your colleagues who could not make it today. Next slide, please. So it gives me great joy to tell you that we're done on time, actually with 3 minutes to spare. Thank you for your participation, everyone involved. Our next meeting will be a MISHC TAVR webinar on June 17th from 6 to 7:30. You'll have more news via email from Pam and Ms. Benchy and the rest of the group about the agenda and our speakers for the day. We welcome speakers from everyone in the consortium, people who want involved in presentations, people who want involved in the issues I discussed. But thank you, have a good evening, and I really was great seeing you all and great talks today. So hopefully this is the beginning of the continuation of what we've been doing in the last few years. And I hope this was fruitful for all of you. Have a good night.
Thank you. Good night.